Okay, let's unpack this. You've handed us a stack of your revision notes all about understanding Parkinson's disease.
Right.
Our mission today is to really dive deep into that material, pull out the absolute most important insights, connect the dots, and build a really high-yield, memorable overview. Perfect for revision.
Exactly.
Think of this as taking your focused study and turning it into a clear, concise mental map.
Yeah, and what's fascinating about tackling complex topics like Parkinson's for revision is finding ways to synthesize those detailed notes into something truly useful, something you can actually recall easily. Getting the core concepts clear makes everything else kind of fall into place.
Absolutely. So let's jump right in at the beginning then. Your notes lay out the fundamental question: what is Parkinson's disease? At its heart, what are we actually talking about?
Okay, so at its core, Parkinson's is a progressive neurodegenerative disorder.
Progressive, meaning it gets worse over time.
Exactly. It's a condition affecting the brain that unfortunately does progress.
Yeah.
The central issue, as your notes really highlight, is the progressive loss of a very specific type of brain cell.
Okay.
We're talking about the neurons that produce dopamine. And these cells are located in a small but really critical area deep in the brain called the substantia nigra.
Substantia nigra, got it. And why is losing dopamine in that specific spot such a big deal?
Well, because those dopamine neurons in the substantia nigra are absolutely crucial for controlling movement.
Right.
When they degenerate, they just can't send enough dopamine signals to other parts of the brain, particularly the basal ganglia. Think of the basal ganglia as like the brain's main control center for voluntary movement.
I see.
So less dopamine disrupts this whole system, and that leads directly to the motor problems we typically associate with Parkinson's.
Okay.
Your notes also clarify something important: Parkinsonism. That's a sort of general term for symptoms like slow movement plus tremor or rigidity. Parkinson's disease, which is the focus here, is the most common cause of Parkinsonism.
Yeah.
And it's specifically due to this dopamine cell loss we've been talking about.
Got it. So Parkinsonism is the umbrella term. Parkinson's disease is the specific cause linked to dopamine loss in the substantia nigra, messing up the basal ganglia's motor control. That makes sense.
Precisely.
This gives us those key movement issues. Now, the big mystery, right? Why does this actually happen? What's the root cause leading to this degeneration?
Yeah, that's where the notes point to a pretty complex picture. The truth is the exact cause isn't fully known. That's important to remember.
Okay.
It's generally believed to be a combination of factors, mainly genetic predisposition and environmental influences.
Oh, a mix.
A mix, yeah. Your notes mention that while some cases, a minority, are linked to specific inherited gene mutations like those in the LRK2 or GBA genes you've listed, the vast majority are sporadic. That means they just appear without a clear family history or a known specific genetic link. And then there are the environmental factors implicated in the notes, things like exposure to certain toxins, pesticides, that sort of thing.
So it's not usually one single smoking gun, more like a combination of our genes and what we're exposed to over time. How does that actually combine to cause the damage at the cellular level, the pathophysiology?
Right, the pathophysiology. So the core mechanism is the death of those dopamine neurons in the substantia nigra.
Okay.
This disrupts the incredibly complex circuitry within the basal ganglia, which relies heavily on dopamine for smooth, coordinated movement signals.
Makes sense.
When dopamine levels drop significantly, those circuits just malfunction. Your notes specifically mention the ventral part of the substantia nigra being key here.
Right.
And that leads to reduced dopamine in the striatum, which is a major part of the basal ganglia.
I see.
The notes also briefly point out that, similar symptoms could be caused by certain drugs or toxins that interfere with the dopamine system.
Ah, okay.
But that's drug-induced Parkinsonism, which is distinct from Parkinson's disease itself.
Okay, so the why is complex, multifactorial, but the how is clearly linked to this dopamine system failure in the basal ganglia circuits. Got it. Who typically gets affected by this, and how common is it?
Well, the risk factors are multifaceted, which lines up with that complex etiology we just talked about. Age is the biggest one.
Right.
The risk increases dramatically as you get older. Genetics definitely play a role. As we mentioned, family history is a risk factor, and those specific gene mutations increase susceptibility. Environmental exposure, particularly to things like toxins and pesticides, is noted in your material.
Okay.
There's also a slightly higher prevalence in males compared to females, roughly a 2.1 ratio mentioned.
Interesting.
And maybe a little quirk from memory from your notes. Some studies hint at a slightly higher incidence for people born in the spring.
Born in the spring. That's definitely a memorable detail. Okay, and what do the numbers tell us? How prevalent is it?
Your notes give some solid figures, especially in a UK context. It's estimated to affect about 1 in 350 adults over the age of 40.
1 in 350 over 40.
Yeah. The typical age at diagnosis is around 65. It's highlighted as the second most common neurodegenerative disorder in the UK, right after Alzheimer's.
Wow, second most common.
And the age-related increase is really quite stark. Your notes cite figures rising from just, maybe 4 or 5 cases per 100,000 in younger adults
Yeah.
to over 1,700 per 100,000 in the 80 to 84 age range.
Gosh, that really shows how much age impacts the risk.
Absolutely. It really underlines it. And that 2.1 male ratio is reiterated.
Yeah.
Plus potential racial variations are mentioned too.
Okay. Those numbers definitely paint a picture of the significant impact, especially on the aging population. All right, let's get to what the disease actually looks like. If you suspect someone might have Parkinson's, what are the classic clinical features described in your notes?
This is a really key section for revision, yeah, because the diagnosis is primarily clinical.
Right.
The core motor symptoms are often remembered using that mnemonic, TRAP. Even if it's not explicitly called TRAP in your notes, the concepts are definitely all there.
TRP. Okay, let's break that down. T.
T is for tremor. This is typically a resting tremor. That means it happens when the limb is relaxed, maybe hands resting in the lap.
Okay, resting tremor.
It often has that characteristic pill rolling quality, sort of like rolling a pill between thumb and forefinger. Usually happens at about 3 to 5 cycles per second, so 3 to 5 hertz.
Right.
And importantly, it often improves or even disappears with voluntary movement. Often starts on one side of the body asymmetrically and may spread later.
Okay. T is tremor.
R is for rigidity. This is stiffness. Increased resistance when you try to passively move someone's limb.
Like trying to bend their arm.
Exactly. It can feel smooth and constant, like bending a lead pipe, or it can feel jerky, which is called cogwheel rigidity. That's when a tremor is kind of superimposed on the stiffness.
Ah, cogwheeling.
Yeah. And like with the tremor, it often starts unilaterally, just on one side.
Okay. TRA.
A is for akinesia, or more commonly, bradykinesia. This is arguably the most important symptom for diagnosis, according to your notes.
Bradykinesia, slowness.
Slowness of movement, yes.
Yeah.
Akinesia technically means absence of movement, but bradykinesia is what you usually see. It shows up as difficulty starting movements, a significant reduction in the speed, and also the amplitude, the size of repetitive actions. Like if you ask someone to tap their fingers quickly.
Okay.
It also includes just general slowness and what's called poverty of movement, less spontaneous movement, reduced facial expression, maybe less arm swing when walking. Shuffling steps fall under this too.
Right, the shuffling gait. Okay, TRAP.
T is for postural instability, difficulty maintaining balance. This tends to become more apparent in the later stages of the disease.
Okay.
It's often assessed clinically with something called the pull test, seeing how well someone recovers their balance when pulled gently backwards.
Aha, right.
And this symptom is a major contributor to falls, unfortunately.
That TRAP mnemonic is super helpful for remembering those core motor issues. Tremor, rigidity, akinesia, bradykinesia, postural instability. But Parkinson's isn't just about movement, is it? Your notes detail a whole range of non-motor symptoms, too.
Absolutely. That's a crucial point. The non-motor features are incredibly common and can have a huge impact on quality of life. Some, like loss of smell, can actually appear years before the motor symptoms even start.
Years before, wow.
Yeah. Your notes list quite a few. Loss of sense of smell, that's hyposmia. Cognitive impairment, which can range from mild difficulties right through to dementia in later stages. Mood changes are very common, depression, anxiety. Sleep disturbances are a big one, including REM sleep behavior disorder, where people physically act out their dreams.
Right.
And widespread autonomic dysfunction. That's the nervous system controlling automatic body functions.
So what does that involve?
Well, issues like chronic constipation, dizziness when standing up, that's orthostatic hypotension, excessive drooling, or coeluria, and bladder problems.
Okay.
Other notable features mentioned include that reduced, sort of mask-like facial expression facies, a tendency towards a flexed, stooped posture, small handwriting micrographia, significant fatigue, pain, and sometimes nausea or vomiting.
It really is a systemic disease, affecting so many different parts of the body and brain. And the notes mention how gait specifically changes as the disease progresses.
Yes, absolutely. As the disease advances, the gait problems often become more pronounced. Those shuffling steps we mentioned are common. Unsteadiness, and something called festination.
Festination.
Yeah, it's where a person unintentionally speeds up their walking in small steps, almost like they're trying to catch up with their own center of gravity. Can look like they're rushing forward.
I see.
Falls become a major concern due to that worsening postural instability. Cognitive issues can also start to impact walking, and your notes mention a form of gait disorder called gait apraxia in later stages.
Okay, so we know what it is, the potential causes, who's at risk, and what it looks like, both motor and non-motor. How do doctors actually diagnose this based on your notes? What investigations are helpful?
Right, this is a critical point for revision. The diagnosis of Parkinson's disease is primarily clinical.
Clinical, based on symptoms.
Exactly. It's based on identifying that combination of symptoms we just discussed, specifically the presence of bradykinesia, plus at least one of the other key motor features, resting tremor, rigidity, or postural instability.
So there isn't like a definitive blood test or single scan that just says, yes, this is Parkinson's.
That's correct, according to the material provided. There are no specific lab tests or standard imaging methods that definitively diagnose Parkinson's disease itself.
Okay.
The main role of investigations, as outlined in your notes, is really about ruling out other conditions that can mimic Parkinson's.
Ah, so looking for other causes.
Precisely. Things like essential tremor, which causes tremor but has a different underlying mechanism, or Parkinsonism caused by certain medications, or even other neurodegenerative conditions.
So what kind of tests do they use then to rule things out?
Your notes mention neuroimaging, like MRI scans of the brain. These are mainly done to exclude other structural problems, things like strokes, tumors, or hydrocephalus that might cause similar symptoms. They specifically highlight dopamine transporter imaging, often called DAT scan in the UK.
PET scan?
Yeah, it's a type of SPECT scan. It uses a radioactive tracer that binds to dopamine transporters in the brain. In Parkinson's disease, these transporters are reduced because the dopamine cells are lost.
So it shows the dopamine system isn't working right.
Exactly. It can help differentiate Parkinson's disease from conditions like essential tremor, where the DAT scan would typically be normal. Your notes mention NICE guidelines recommend this scan for that specific purpose, differentiating when there's diagnostic uncertainty.
Okay, that makes sense.
Other potential investigations listed for ruling things out include P scans, possibly genetic testing in very specific clinical situations, and maybe olfactory testing, given that early loss of smell.
Right.
But the notes really emphasize the importance of referral to a specialist, usually a neurologist with expertise in movement disorders, for an accurate diagnosis. Their clinical judgment is key.
So a specialist's eye is crucial, backed up by tests mainly to exclude the mimickers. Okay. Once that diagnosis is made, what are the management options outlined in your notes? How is it treated?
Management is typically overseen by that movement disorder specialist or a team. The main goal is to control symptoms and maintain quality of life because, as we know, there isn't currently a cure. Your notes describe a sort of tiered approach, often based on how much the symptoms are impacting the person.
Okay, what's the starting point for treatment then?
Well, it depends. If the motor symptoms, the tremor, stiffness, slowness, are significantly affecting a person's quality of life and their daily activities,
Yeah,
that levodopa is generally considered the first-line treatment. It's the most effective.
levodopa. Okay. And if the symptoms aren't too bothersome yet?
If the motor symptoms are present but not really causing problems day to day, the notes suggest other options might be considered first. Things like dopamine agonists or MAOB inhibitors, maybe delaying levodopa slightly.
Okay. Can you give us a quick rundown of the main drug classes mentioned in the notes and sort of how they help?
Sure. The notes cover the key players. Levodopa. This is really the gold standard for motor symptoms. It's a precursor molecule that the brain converts directly into dopamine, replacing what's lost.
Ah, so it tops up the dopamine.
Exactly. It's always given combined with another drug, a decarboxylase inhibitor, which stops the levodopa being broken down in the body before it reaches the brain.
Right.
It's very effective, but long-term use can lead to complications like motor fluctuations, where the effect wears off between doses, or people switch unpredictably between on good mobility and off poor mobility states, and also involuntary movements called dyskinesias.
Okay. Side effects too.
Yeah, common ones mentioned are things like dry mouth, maybe dizziness or low blood pressure, sometimes confusion or psychosis at higher doses.
Got it. What about the others? Dopamine agonists.
Dopamine agonists. These drugs don't actually replace dopamine, but they mimic its effects by stimulating the dopamine receptors in the brain. Examples like ropinirole or pramipexole are mentioned.
Okay.
Your notes point out that some older ones, like bromocriptine, carry risks like fibrosis. A really notable potential side effect with agonists is impulse control disorders.
Impulse control, like what?
Things like compulsive gambling, shopping, eating, or hypersexuality. It's something patients need to be warned about. They can also cause sleepiness, hallucinations, or swelling.
Right. Important to know. What else? MAOB inhibitors.
MAOB inhibitors, like selegiline or racetline. These block an enzyme, monoamine oxidase B, which breaks down dopamine in the brain. So they help preserve the dopamine that's still being produced.
Okay, makes sense.
COMT inhibitors, like entacapone. These are typically used with levodopa. They block another enzyme involved in breaking down levodopa itself, helping to smooth out the response and reduce that wearing off effect.
So they make levodopa last longer?
Essentially, yes. Make the dose more effective for longer.
Okay. Any others mentioned?
Amantadine, an older drug. Its exact mechanism isn't perfectly clear. Maybe it affects dopamine release or has other effects. It can help with motor symptoms and sometimes with the Blefeldum-induced dyskinesias. Side effects like confusion or skin discoloration, levodo reticularis are noted,
Right.
and antimuscarinics, these block acetylcholine receptors. They were used more historically for tremor and rigidity, but less so now for Parkinson's itself because of side effects like confusion, dry mouth, constipation, especially in older people.
Yeah.
Your notes mentioned they're still useful sometimes for managing excessive drooling, cyoluria.
Okay, quite a few drug options.
Yeah.
And the notes talk about managing the trickier aspects, like those fluctuations.
Yes, managing motor fluctuations wearing off on
Ugh.
dyskinesias is a
Right.
big part of ongoing care. It often involves careful adjustment of levodopa doses and timing, maybe switching to longer-acting formulations, or adding in those other drug classes like agonists, MAOB inhibitors, or COMT inhibitors. For really advanced disease where oral meds aren't controlling things well, your notes mention options like subcutaneous apomorphine, either intermittent injections or continuous infusion via a pump, or duodopa, which is levodopa-carbidopa, delivered as a gel directly into the intestine via a tube.
Wow, okay. More intensive options. And it's not just medication, right? Your notes definitely mention other crucial support.
Oh, absolutely essential. Management is very much multidisciplinary. The notes highlight the importance of Parkinson's specialist nurses, who are often key coordinators, physiotherapists for exercise, movement strategies, balance training, occupational therapists helping with daily living adaptations, speech and language therapists for swallowing issues and voice problems, and dietitians for nutritional support. It's a team effort.
That makes a lot of sense. And for certain patients with advanced disease, there was something else mentioned. Surgery.
Ah, yes, deep brain stimulation, or DBS. This is a surgical option for some patients, typically those with significant motor fluctuations or tremor that aren't responding well enough to medication anymore.
How does that work?
It involves surgically implanting thin electrodes into specific deep brain areas involved in motor control off of the subthalamic nucleus or globus pallidus, as mentioned in your notes. These electrodes are connected to a pulse generator, like a pacemaker, implanted under the skin. It sends electrical impulses to help regulate the abnormal brain activity causing the motor symptoms.
And does it work?
It can be very effective in improving motor control, reducing fluctuations and dyskinesias, and allowing medication reduction. But it is brain surgery, so it carries risks like bleeding, infection, or potential side effects like confusion or speech changes, as your notes point out. Careful patient selection is key.
Okay, that covers the management side pretty thoroughly. Now, looking ahead, what's the typical prognosis, and what kind of complications might someone with Parkinson's face over time, according to your notes?
Well, Parkinson's is, as we said, a progressive condition. It will worsen over time, but the rate of progression varies hugely from person to person.
So it's quite individual.
Very individual. While there's no cure yet, early diagnosis and effective management, especially with levodopa and the multidisciplinary team, can significantly improve symptoms and maintain function and quality of life for many, many years. Factors like age at onset, the initial severity, and how well someone responds to treatment can influence the progression.
Okay.
Your notes do mention that compared to the general population, there's unfortunately an increased risk of mortality over the long term, and also a significant risk of developing dementia, particularly in later stages for some individuals.
Right, and the complications. Your notes seem to list quite a few potential problems.
They do. Complications are a major part of managing Parkinson's long term. They can be broadly split into the motor issues becoming more complex, like those fluctuations and dyskinesias we discussed getting harder to manage, and a really wide range of non-motor problems that can develop or worsen over time. For revision, grouping these non-motor ones might be helpful, like your notes seem to.
Okay, how are they grouped?
Well, you have mental health and cognitive issues. Depression and anxiety remain common. Apathy can be a problem. Dementia, as mentioned, can develop. So it's mentioned trying cholinesterase inhibitors for this. Those impulse control disorders are linked particularly to dopamine agonists. And psychosis, hallucinations, or delusions can occur, especially later or with medication changes. Notes mention quetiapine or clozapine might be needed. Autonomic problems. Persistent constipation is very common. That orthostatic hypotension causing dizziness and falls can worsen. Notes mention medication review, maybe drugs like midodrine. Difficulty swallowing, dysphagia, is a serious risk, potentially leading to aspiration pneumonia. Drooling can be socially difficult. Notes mention treatments like glycopyrronium bromide. Weight loss, excessive sweating, and bladder control issues, urgency, frequency are also listed. Sleep issues. That REM sleep behavior disorder can persist. Problems like waking up stiff and unable to move easily during the night, nocturnal akinesia, can disrupt sleep. Notes suggest levodopa or uvigotine patch might help. Other issues, things like pain, fatigue, nausea can continue. And in the very late stages, complications related to reduced mobility become significant risks, like pneumonia or pressure sores.
That's a really comprehensive picture of the potential challenges over time. And your notes mention one specific life-threatening complication.
Yes, they highlight something called acute akinesia, sometimes referred to as a Parkinson's crisis.
What's that?
It's a sudden, severe worsening of all the motor symptoms. Extreme rigidity, immobility, often with difficulty swallowing. It can be triggered by things like infection, dehydration, or abrupt withdrawal of Parkinson's medication. It's a medical emergency requiring urgent hospital admission and treatment.
Wow. Okay, so let's try and pull this all together. We've synthesized your notes into hopefully a high-yield review. We've covered the definition that progressive loss of dopamine neurons in the substantia nigra leading to movement problems and the broader concept of Parkinsonism.
Right.
We explored the complex, often unknown mix of genetics and environment causing this degeneration and how that disrupts the basal ganglia motor circuits. We looked at who's most at risk, primarily age, genetics, environment, male gender, and that memorable spring birthday detail, and saw the stark numbers showing its prevalence, especially with age.
Yeah.
We detailed the classic motor features using the 2-rap mnemonic tremor arresting, rigidity, lead pipe cogwheel, akinesia, bradykinesia, slowness, the key feature, and postural instability later, causing falls. And we didn't forget the huge array of non-motor symptoms, from smell loss and constipation right through to cognitive issues and sleep problems.
Crucial non-motor parts.
We clarified that diagnosis is clinical, made by specialists, backed by investigations like MRI or DAT scan, mainly to rule out other conditions.
Exactly.
We covered the management strategies, focusing on replacing or mimicking dopamine with medications like levodopa and dopamine agonists, managing side effects and fluctuations, the vital role of the multidisciplinary team, and advanced therapies like DBS for specific cases.
The whole package.
And finally, we discussed the prognosis, progressive but variable and manageable for years, and the significant long-term motor and non-motor complications that can arise, including that serious Parkinson's crisis.
So what does this all mean for your revision? I think understanding Parkinson's disease really requires piecing together all these different elements, from the microscopic level of dopamine loss in a specific brain area, right up to the broad spectrum of symptoms people experience and how they're managed day to day. Focusing on those core mechanisms and the key clinical features, like remembering TRIP for motor symptoms and that the diagnosis is primarily clinical, that's really crucial for solid recall when you're revising. These notes, structured like this, provide an excellent foundation.
Absolutely. And maybe a final thought to leave you with. Despite all this incredibly detailed knowledge laid out in your notes and everything we've discussed about the downstream effects, the exact initial trigger, why those critical dopamine neurons begin to die in the first place for most people, well, that remains one of the biggest unanswered questions in neuroscience. Something powerful to ponder, perhaps, as you continue your learning journey. For more resources that might be helpful for medical revision and learning, and particularly around exams like the MSRA, you can check out passthemsra.com and also freemsra.com. Thanks so much for joining us on this deep dive into your Parkinson's revision notes. Keep learning, keep revising, and we'll catch you next time.